welcome back to my channel for another recording. My name is Manny Barbosa and I am an ICU educator and an ICU nurse for 30 years. So today's topic is about ICU Liberation. So for those who are new in the ICU, you're probably wondering, what is ICU Liberation? Who are we liberating? So it's actually many hospitals is using it differently. Like some are calling it rethinking ICU, some are calling it ICU Liberation. So, but the Society for Critical Care Medicine, SSCM, is actually calling it ICU Liberation. So just giving you an idea, what is ICU Liberation? So it's purely for ICU nurses to know and understand. Okay, so the ABCDEF Bundle. A stands for Assess, Prevent, and Manage Pain. Imagine if you have a patient on a ventilator and you have that tube in your mouth, right? Imagine if you have that tube, it's not comfortable. So the tendency is for the patient to reach for that tube, right? And try to pull it out. But you don't want that patient to do that, right? So what do? He's now fighting the ventilator, and so what the ICU nurses do will increase sedation, right? So you just don't hear it from the doctor, but the RT will ask you, hey, would you like to go up with his sedation? Because he's fighting the vent, he's agitated. So in the old days, as I've mentioned, I've been an ICU nurse for 30 years. We never had this. This is an evidence-based practice that I think we started in, as far as I remember, 2010, like the beginning of 2007. We already have a project. I was part of that project wherein we need to attend seminars. I think it's Dr. Eli from Vanderbilt Medical Center who started this, and it was indeed a very, very good idea to do, because when we fully implemented it in our unit, we were able to be walking our patient on mechanical ventilation. They're wide awake, and then we saw how the length of stay in the ICU decreases, and the mechanical ventilator or the vent days also decreases, and eventually mortality rate also went down. So the first question is the A. When you are thinking about A, assessing and preventing and managing pain, so we normally would like to think the PAD guidelines, the pain, agitation, and delirium guidelines. So there are a lot of materials out there. You can get it from Google, and it talks about like how do we need to manage pain, okay, so that we will prevent them from getting more delirium and getting agitation. So sometimes when you give them sedation, like we normally give them propofol, right? But we all know that propofol doesn't have any analgesia or analgesic property. So now we're adding fentanyl. So propofol plus fentanyl. Then you're managing the pain, and at the same time you're paralyzing them. Then we understood completely that we need to maintain some sort of a sedation scale, right? So sedation scale. In the ICU, they're using Chem ICU and RAS. So Chem ICU is confusion, agitation. I think it's monitoring in ICU. And you're using the Richmond agitation sedation scale. You have to make sure you understand how to use the RAS score, because it starts from 0 where your patient is calm, and then it becomes positive 1, 2, 3, 4. The higher the number, the more agitated your patient. And negative 1, 2, 3, 4, 5. The more negative your patient, the more that they are unarousable. So you have to pay attention the 1 and 3. Negative 1 and 3 is supposed to be voice. So if you're calling your patient's name, they should start waking up. They're trying to wake up. They can sustain it for more than 10 seconds or less than 10 seconds, or they're trying. However, if you start touching them to wake them up, now you are in the negative 4 and 5, which means the sedation is too much. So that's when we say, okay, go slow with your sedation. So these are the things that an ICU nurse should understand, okay? If your patient is getting your pain management and you're assessing the RAS, and then you're assessing their delirium, you then move to B, which is your spontaneous awakening trial. So how did we implement spontaneous awakening trial? It became very challenging to the nurses because at one point we don't know when to start stopping their sedation. At one point, we all agreed that night shift should start the sedation vacation. We used to call it sedation vacation, but now it's SAT, Spontaneous Awakening Trial. So SAT, Spontaneous Awakening Trial. Okay, what is SAT? You stop your sedation, right? Wait until the patient starting to wake up. If the patient starting to wake up, you have to look for the vital signs. Is it stable? Are the vital signs remain stable? Heart rate, blood pressure, right? And respiratory autosat. If your patient did not tolerate the spontaneous awakening trial because heart rate went up, patient blood pressure went down or up, patient become really agitated, then he failed, right? We call it failed. But I want you to make sure that you do it again. So if the night shift said he failed SAT, I'm the day shift, I should be starting my SAT again, like after, if I'm ready, like after I done everything, probably will start like around 10 a.m. So I'm gonna retry it again, but this time, because propofol is, the half-life is so quick, turn it off, patients start waking up. So what we did and what we found out is that we then converted into Presidex. Okay, so the sedation that we are using is, it all depends on the doctor's order. We gave them Presidex, so that when you turn off your propofol, they are more calm. Okay, and also what I did that I saw effective is, if I intend to do the SAT, let's say I'm gonna do it at 10, I want to make sure that the family members are at the bedside. Okay, the family members. So the wife, daughter, or whoever, whoever that this patient is familiar. Because imagine you don't know anything. Like, the last time you recall was you were in the emergency room, right? And then all of a sudden, you're very unfamiliar with the location, the people. So if you have a family member around them when you start waking them up, I've seen how the wife, the daughter, the brother, the sister was able to ease and make the patient cooperate in terms of relax, take a deep breath, pay attention, things like that. So if you do that, then of course this thing, we're all gonna be stabilized. Let's just say your SAT was a success. Your patient start waking up and stable. You met the criteria, you pass. Then you have to let the RT know your patient is wide awake, so that RT can do the spontaneous breathing trial. So the SBT. So SBT again is done by the RT. You need to communicate it with them ahead of time so that they'll come to the bedside, and making sure that there is a parameter to, again, that the patient needs to meet and pass. So let's say he did good and now he is on pressure support. So we will continue that SAT, only pain medication. So I will continue the fentanyl, low dose for pain. RT, put the patient on pressure support. Then now what? You need to involve your physical therapy. Okay, PT or physical therapy. So at one point we trained our nurse's aide to be a patient technician. So they train the CNA how to walk or get up the patient from the bed so that we can start walking them. Okay, so that's something that you need to, that your unit or the team should consider. All right, so the next one now is the choice of sedation. So choice of sedation include, okay, as I've said, Presidex, Propofol, fentanyl. We try to avoid Ativan and Versed, as the researchers have reported that they have some effect with delirium. Okay, then delirium. So how do you know if your patient is delirious? You need to assess them with your CAM ICU. Okay, you have to ask the patient question, and they need to have a certain score for you to trigger it if they're delirium or not. So prevention of delirium is the ABCDEF bundle. So if you stop their sedation, so we call it wake up and breathe. So patient will start waking up and they can start breathing on their own, and providing some non-pharmacological intervention, like you have to open blinds so that there's a differentiation between day and night. Okay, and then you would provide range of motion and exercise and ambulation. So that's why your early mobility and exercise. So early mobility and exercise. So where I came from, we have levels of activity. So 1, range of motion in bed. If you think they failed, you do range of motion. And then 2, level 2, you sit them at the edge of the bed. Then so forth and so on until your patient is walking with the rest of the team. So when you're ambulating your patient, you have to make sure that you have the whole team around. So you have a wheelchair standby just in case the patient will get tired, put them in a wheelchair, right? And then you have a walker. So we have that high walker wherein it's a U shape, so the patient can just put his arm around it while he's walking. And then you have your pump for your fentanyl, and sometimes we just discontinue some of the medication that he doesn't need during ambulation. Then family members are there cheering the patient, and we have the PT to guide for posture. We have the primary nurse. We have the RT on the ventilator. We have a portable vent that we put in the wheelchair so that patient can use the ventilator while we are ambulating. So what we did there is we will measure how far the patient walked. So we put a marker either on the ICU flooring or like a marker that's hanging on the wall or on the ceiling that says 500 yard, things like that. And we will gradually do this depending on patient's tolerance, and if they tolerate it well, we will continue. If they start to get tired, we will stop, and then we'll do it again. So the end point is you have to extubate the patient at one point. So the intensivist will tell us he did well today, we will extubate him later today, so that everybody will be in one page, so that we will do extubation plan like around 4 p.m. for example. RT will then do the mechanics like around 1 p.m. to reassess if the patient is ready, including secretions, including cough leak test for swelling, and then the doctor or intensivist will agree with the chest x-ray if everything is okay, ABG confirmatory if the patient is stable. So that's how we implemented the ABCDEF bundle in a nutshell. So the objectives is to optimize pain management. You break the cycle of sleep sedation and prolonged mechanical ventilation. You reduce the incidence of duration of delirium. You improve short and long-term ICU, and you reduce the healthcare costs. So I got this from the website. Don't forget about Dr. Dre, the disease, especially what was the reason why they're in the ICU. Is it because of sepsis, chronic COPD, CHF? And then drug removal, so that's the only way to do it is your SAT, spontaneous awakening trial, and you do not give them too much narcotics or Ativan. And then the environment, okay? So we need to provide sleep and rest. So what we've done in that ICU was we did a PDSA on how to improve rest and sleep at night. So there is clustering of nursing care. There is putting the phone into a vibration mode or forward it to a portable phone where the charge nurse will hold it so that it won't ring, not causing too much noise in the ICU. We provide, plugs. We provide eye covering, things like that. And of course, you address if the patient has hearing aid or wearing eyeglasses, and the noise control. All right. So, the Maslow's hierarchy of needs in the ICU, again, it's also being discussed that physiological, safety, love and belongings, esteem, and self-actualization. So over here, incorporating spiritual values into patient's care, acceptance of new limitation, reconciliation of new identity. So sometimes when they are in ICU, they're sedated for a while, they don't know what happened. So we provide diary, like a small notebook for the family and the staff nurses or any team member that might want to write something in there. And we give that to the patient when we discharge them so that they can read what happened. If we have a picture, photo, we will add it there. Family members might take a photo, put a date, so that they know what happened. Okay. And I think that's pretty much, what is the ABCDEF is all about. So it's all about trying to ambulate the patient as early as possible. You do not sedate them too much. You have to take it in a different approach. So gone are the days wherein they're cruise control in the ICU, sedated, vented, and restrained. So now we are more aggressive in stopping everything and make them get up and walk. All right, well, I hope this helps. Thank you.